Hello, coders. So, this time we're going to talk about two subjects. The endocrine system, which is only a few pages, and the nervous system, which is quite long. So the endocrine system is sandwiched right at the end of where the female genital maternity care is, right before the nervous system. Now, what's interesting about the endocrine system is it's not all endocrine organs. Okay, so the endocrine system organs that we're going to see here are going to be the adrenal glands, the carotid body, the parathyroid glands, the pancreas, and the thyroid gland. So there's not that many main terms because the easiest way to find them is to look under the anatomic site. However, we can look for the procedure name. You can look under adrenalectomy. You can look under parathyroidectomy. You can look up thyroidectomy. But the biggest thing here is, again, it's not all of the endocrine system organs, and that's because the pituitary and pineal are going to be in the nervous system. And when it comes to the ovaries and the testes, of course, they're in their own genital systems. So again, easiest way for main terms, procedure name, or direct anatomic site. So we're going to go through those guidelines first, then we'll come back and we'll go through the nervous system ones. So the endocrine system starts in the bottom of page 384. It starts with the thyroid gland. Again, for pituitary and pineal surgery, see nervous system. So for the thyroid gland, again, there's not a lot we do. We mainly do excisions, but we can do an incision. You can see the incision and drainage of the thyroglossal duct cyst. So again, exactly what it sounds like, making an incision and draining it. We also can do a biopsy. So again, this is very, very common. A lot of times these will be done in the office, in a surgical room, sometimes like once a month or so. And so they can actually do the biopsy themselves and see what's in a thyroid nodule. Again, remember the thyroids, we have two lobes of them, and it sits around the larynx. But on top of these, embedded within the thyroid glands, are four parathyroid glands. The best way I can describe them is the way that a student once asked me about them. Student once asked me, are they like chocolate chips? And I said, actually, they are. If you think of like a chocolate chip cookie, okay? The chocolate chips are individual pieces of the cookie. There's the cookie base, and then there's the chocolate chips. Okay, the chocolate chips are part of the cookie, but they're also their own little being. Same thing with the parathyroid gland and the thyroid. They can affect each other, but they have separate purposes within the body. And so the biggest thing here is if we are going to do an excision of the thyroid gland, are we removing the parathyroids or not? And how much of the thyroid gland are we removing? So for instance, right here, you'll see you'll have with contralateral subtotal lobectomy. So again, contralateral, opposite side. So how much of the thyroid gland do we need to remove? Is it going to be the complete left or right? Is it going to be all of it or just part of the left or right lobe? And again, what are we doing with those parathyroid glands? So again, we can see we can do thyroidectomy total or subtotal for malignancy, again, with limited neck dissection, with radical neck dissection. Again, this is a thyroidectomy following a previous removal of a portion of the thyroid. So again, what specifically are we doing when we're removing the thyroid from this patient? Then we get to this little section of the parathyroids, thymus, adrenal gland, pancreas, and carotid body. Again, the parathyroidectomy or exploration, it's the same code, whether we remove it or explore it. Again, we can do a re-exploration or we can do it through a sternal split or transthoracic approach. Again, we can go in through the neck, we can go in through the thorax, or we can go in through the sternum. 60512 is the parathyroid autotransplantation. Again, if we're removing the thyroid gland and the parathyroids are still functioning, we can move it to the opposite thyroid gland. We have the thymectomy, removal of the thymus. Again, it doesn't do a lot for us as adults, but it hides underneath our sternum. It's really there as we're growing, as we're children, to deal with our immune system, and still does deal with our immune system as adults. It's just not nearly as important. Then we have the adrenalectomies again, and again, this is a big one. So this is an adrenalectomy, partial or complete, or exploration of adrenal gland with or without biopsy. So again, this is either or. This can be a removal or an exploration to find out what's going on. And so, the big thing is when we get to this, how are we doing it? We also, for the removal of the adrenal glands, can do a laparoscopic adrenalectomy. So again, how are they describing the procedure? Are they describing it as an open procedure or as a laparoscopic procedure? And that's about it. There's not much. There's only those couple of handfuls of endocrine glands that we are going to be dealing with in this section. So the biggest one is anatomic site or direct procedure name. But let's talk a little bit about the nervous system. So the nervous system, when we come here again, the easiest ways we can look up the procedure name, like a craniectomy. We can look up the anatomic site, like the brain, or we can look up the condition, like a cerebrospinal fluid shunt. And so it depends on what we're doing here. So number one, don't forget that on page 388 in your code book, you have a picture of the most common nerves, both central and peripheral nerves, that go out to the body. On page 389, we have the different separations of the parts of the brain in different colors. So don't forget that that's there, because those can be very, very helpful. So the first thing that we are going to keep in mind is, again, what parts are going to be covered. So we're going to see everything from the brain, the spinal cord, the meninges. Remember, the meninges are the coverings of the brain, and there are 3 of them. The skull itself, the spine, the brain stem. We're also going to deal with the cranial bones, because again, that's part of these procedures. Sometimes we have to go into the cranial bone, like to do a craniectomy or craniotomy. Again, we can look up the nerves themselves, all different parts of the body. We're going to see some neurostimulators in this area. We can also look up skull base surgery and spinal canal. So again, we have lots of different things that we can look under, as well as, of course, the actual name of the procedure. So the first thing that we're going to see is we're going to see all these different punctures. So we're going to see everything about burr holes. We're going to see trephines in here. So when it comes to dealing with the skull, the meninges, and the brain, we only go into the brain when we absolutely have to, and sometimes we do because of a hematoma or a tumor or an abscess. There are some very interesting parasites that can actually create these kind of large, clear tumors in the brain. And so, again, what are we going in to do? When they're actually dealing with drilling into, when we see things like a twist drill hole or a burr hole and things like that, think about small pieces of actual construction equipment. So for instance, if you've ever seen the piece of equipment they use to make the hole where the doorknobs go, okay, it's a round piece, it's very jagged, and it runs around in a circle so they can just go through the door and create that door hole so they can insert whatever type of handle they want. We have a small version of that that does these little burr holes. And again, it's usually to remove something or on occasion to inject, as you can see here. The other thing I want you to remember is right here under 61020, fontanelle. So remember, when babies are born, their skull is not sutured. Their skull should not suture until they're closer to 6, 7, 8, 10 years old. So what they have is they have a fontanelle. That's what we call these soft spots on the baby's head. Basically, when they're born, it's cartilage. We have to remember babies are born with more cartilage than adults. They're actually born with more bones because the cartilage hasn't solidified yet, just like it hasn't on the skull. And so again, if this is something for a neonate or a very young child, then we might go through the fontanelle. However, if someone has had a burr hole because of an abscess, a hematoma, an infection, a tumor, then again, we can go back through the same one, or we can make a separate hole into the skull itself. Now, again, for these, you can look up things like burr hole as well. So you can look up what we're doing to that part of the body. As we continue on, you're going to see the craniectomies and craniotomies. So again, the craniectomies, sometimes we're only removing a small piece of the skull, and other times we're removing the entire top of the skull. So every time I get to this section, I always think of the movie Hannibal. So Silence of the Lambs came first, and they did Hannibal. And in Hannibal, towards the end of the movie, Ray Liotta's character, who is investigating Hannibal Lecter, gets caught by him, and there's a scene where he takes off the top of his skull. Now, I can tell you, because I've watched the special features, that is a robot puppet. So Ray Liotta's brain was not really open, but this is what's interesting. When we think of the nervous system, we think of the fact that we have sense receptors. Okay, we have touch receptors on our skin. We have sense receptors in our nervous system that allows us to feel what's going on. But the one place in our nervous system that does not have any sensation is the brain. So they can take off the top of the skull and the patient will not feel them poking and prodding at the brain because the brain itself does not have any nerves. I know that that sounds weird, but that's really the truth behind it. And so again, we try not to do things like take the full top off the skull if we don't have to, but it depends on the issue. Depends on what we need to do and for what reason. Again, when we think of these, a lot of times we're thinking about abscesses and infections and hematomas, but we also have to think other accidents and injuries where possibly the skull has gotten crushed, where we have to go in and fix an area. Or again, think about really invasive cranial surgery that we'll have to do to remove something like a tumor. And so when we're doing these, we really need to know where are we going and how much. So for instance, you'll see things like superintorial, infraintorial, intracerebellar. Where specifically are we doing these craniectomies and craniotomies? So again, if we're either removing part of the skull or making incisions into the skull, we need to know what part of the skull are we actually going into. And don't forget that although when we think of the word orbit, we're thinking of eye and ocular adnexa, we also have to remember that the orbits, which are the bones of our eyes, because of how close everything is, that we might also see orbits. So for instance, if you look at code, I just saw it, 61332, exploration of orbit, transcranial approach with biopsy. So again, what specifically are we doing and where are we doing it? When it comes to the nervous system, like all systems, specifically, where are we? So just like when I was talking about the cardiovascular system, we need to know artery, vein, capillary, and where. Here, we need to know central nervous system, peripheral nervous system, autonomic nervous system, and where. Or again, we're cutting into the brain, where. Now, we have a whole series of guidelines for surgery of the skull base. Okay, and these are for different types of lesions. So this could be cancer. Most likely, we're going to find out that it is a tumor of some sort. But there are other lesions that we could look for as well. So what I've done here, and what you'll notice, is I have 4 different colors. The yellow is for general guidelines. The pink is for the approach procedure, and I've highlighted the approach codes in pink. The orange is for the definitive procedure, and I've highlighted all of those in orange. And the blue is for repair and reconstruction, and I've done the same thing. So let's go through what these are and what we're going to be doing. So the surgical management of lesions involving the skull base, which is base of the anterior, middle, and posterior cranial fossa, often requires the skill of several surgeons of different surgical specialties working together or in tandem during the operative session. These operations are usually not staged because of the need for definitive closure of the dura, subcutaneous tissue, and skin to avoid serious infections such as osteomyelitis and/or meningitis. So right there, they're telling us that usually we're not just doing one part of the procedure. We're doing at least two or possibly all three at the same one. But biggest thing, multiple specialties. We could be dealing with co-surgeons. We could be dealing with a team here. So let's learn about each part of this. So number one, the approach procedure is necessary to obtain adequate exposure of the lesion. Okay, so again, adequate exposure of what shouldn't be there. Two, the definitive procedure is necessary to biopsy, excise, or otherwise treat the lesion. And three, the repair and reconstruction of the defect that present following definitive procedure. So anything that we might have to repair or reconstruct, depending on how much we had to remove during the definitive procedure. Now, again, we need to know where are we performing these. So they tell us, the approach procedure is described according to the anatomic area involved. So the anterior cranial fossa, middle cranial fossa, posterior cranial fossa, and brainstem or upper spinal cord. The definitive procedure always describes the repair, biopsy, resection, or excision of various lesions of the skull base, and when appropriate, primary closure of the dura, mucous membranes, and skin. Remember, the dura is one of the three coverings of the brain. And then the repair and reconstruction is reported separately if extensive dural grafting, cranioplasty, local or regional myocutaneous pedicle flaps, or extensive skin grafts are required. For primary closure, see the appropriate codes, and it sends us back to integumentary surgery. And those are for the different flaps and grafts. So again, the more extensive the procedure is, the more likely we are to need extra codes. And they're telling us right off the bat that if they need an extra code for the repair and reconstruction, we are going to grab those from the integumentary system based off of the specific type of flap or graft that they will need. Now, they go on to tell us, when one surgeon performs the approach procedure, another surgeon performs the definitive procedure, and another surgeon performs the repair or reconstruction, each surgeon reports only the code for the specific procedure performed. So again, this could be 1, 2, or 3 different physicians. If one surgeon performs more than one procedure, like the approach and definitive, then both codes are reported, adding modifier 51 to the secondary additional procedures. So again, what is our surgeon doing? So the first thing, again, the approach procedures. So again, we're going to see the craniofacial approach, okay, and this is extradural. And again, we can see with lateral rhinotomies, again, as we go down, we're going more and more involved into the body. We can do orbitocranial approaches. We also have, let's see, where is it? Under the middle cranial fossa, we have the infratemporal, the orbitocranial, the transtemporal, transcochlear, transcondyle, transpetrosal. So again, how are we getting in? We have the anterior cranial fossa, middle cranial fossa, posterior cranial fossa. So front, middle, or back part. Then we get to the definitive procedures. And again, you can see I've highlighted this in a different color. Again, we have the resection or excision of neoplastic, vascular, or infectious lesion of the base. And again, as we continue to go through here, again, we're going to see base of anterior cranial fossa, base of middle cranial fossa, and base of posterior cranial fossa. So again, what specifically are we doing? What specifically are we looking for? Now, the repair and reconstruction, there's only 2 codes. So again, this is a secondary repair. So remember, as it told us, the definitive procedures includes closure of the dura and the skin and subcutaneous tissue. But if it goes further, if we have to do different types of grafts, and right here, pericranium fascia, tensor fascia lata, adipose, homologous, synthetic grafts, all of these, then we just want to keep this in mind. You know, what specifically are we looking at? All right, so we are now under endovascular therapy. The endovascular therapy codes start on page 394. These guidelines that we're going to go through are on page 395. And as I talked about in some of the other lectures, the biggest thing is, again, we are trying to do as small as possible, whether it's making a simple puncture into the body, using different types of catheters, using different types of imaging to be able to see the body parts. And so what's coming up next is what they're describing that is in these codes. So code 61645, 50, and 51 describe cerebroendovascular therapeutic interventions in any intracranial artery. They include selective catheterization, diagnostic angiography, and all subsequent angiography, including associated radiological supervision and interpretation within the treated vascular territory, fluoroscopic guidance, neurologic and hemodynamic monitoring of the patient, and closure of the arteriotomy by manual pressure, an arterial closure device, or suture. Okay, so there's a lot of things included in these codes. So let's go back to the beginning. Selective catheterization. Remember, there is selective catheterization in the body and non-selective catheterization. Non-selective catheterization means that we are going into a vessel, an artery or vein, and we are staying there. We are not going beyond that vessel. Selective catheterizations means that we are. So we're going through the branches of the vessels in our body. And again, we have to be careful about how they describe where these are. So this is why we have an appendix of all the major arteries in the body that we perform these procedures on. Because again, when we're talking about intracranial arteries, we cannot get to those through the skull, believe it or not. We have to go through places like the arm, the shoulder, or the neck to be able to scope up and get into those intracranial arteries. So getting to the issue, the angiography itself, so being able to use imaging. Again, it includes all the supervision interpretation. So it includes the doctor having to read and write a report that goes along with it. The treatment in the vascular territory itself, the fluoroscopic guidance. Again, that is when the patient is on a surgical table and above them is an x-ray equipment. And again, it's sending a live feed. So it's not taking static images. It's sending a live feed because most of the time when we're talking about catheterization, they're putting in what we call a guide wire, or the catheter itself has some metal in it so they can see where they're going by using the x-ray and the live feed to a computer or television screen. Again, the neurologic and hemodynamic monitoring of the patient. We want to make sure that everything is going fine, with their nervous system and, again, the hemodynamics, because we're inside a vessel that's going to the brain. We want to make sure the blood is properly flowing to the brain. It also is the closure of the arteriotomy. So in this case, they are making a small puncture into an artery to get that catheter in there to do the endovascular therapy. So whether it's manual pressure, literally putting pressure on an arterial closure device, they have different types of clotting agents that are used to help clot things like arteriotomies and venotomies, or a suture. So any of those are also included. So it goes on, because again, these codes are separated by where are we going. So for the purposes of services described by 61645, 50, and 51, the intracranial arteries are divided into 3 vascular territories: the right carotid circulation, the left carotid circulation, and the vertebrobasilar circulation. Code 61645 may be reported once for each intracranial vascular territory treated. Code 61650 is reported once for the first intracranial vascular territory treated with an intra-arterial prolonged administration of a pharmacologic agent. Okay? So when we look at these codes, 61645, percutaneous arterial transluminal mechanical thrombectomy and or infusion for thrombolytic intracranial, any method, including diagnostic angiography, fluoroscopic guidance, catheter placement, and intraprocedural pharmacologic thrombolytic injections. That is 61645. 61650 is endovascular intracranial prolonged administration of pharmacologic agents other than for thrombolysis, arterial, including catheter placement, diagnostic angiography, imaging guidance, initial vascular territory, and 61651 is for each additional vascular territory. So what they're telling us here is 61645, okay, is going to be if we're going in and we're giving an injection and that's it. 61650 is when we are putting that pharmacologic agent in for a prolonged period of time. So it's not just a simple injection, okay? It's kind of a continuous, and it's going on for a lot longer than we're used to. It goes on to tell us, if additional intracranial vascular territories is also treated within the intra-arterial prolonged administration of pharmacologic agents during the same session, the treatment of each additional vascular territories is reported using 61651. May be reported maximally 2 times per day. So again, very important. They're telling us, listen, we can use 61650 with 61651, but 61651 can only be used 2 times per day. So again, we have to be careful. These little guidelines are the types of things that they're going to try to trip you up on when you actually go for something like a CPC exam, because they want to know that you know there's a guideline that goes to how many times. Some of our codes are only once per treatment session, sometimes are once per entire set of treatment sessions. In this case, this is twice per day. That's it. So we have to be careful. It also goes on to tell us code 61645 describes endovascular revascularization of thrombolytic and embolytic occlusion of intracranial artery vessels via any method, including mechanical thrombectomy, which are things like mechanical retrieval devices, going in and grabbing the fatty plaque substance, aspiration catheter, where we go in and we kind of suction it out, and or the administration of agents for the purpose of revascularization, such as thrombolytics or 2B or 3A inhibitors. So again, a couple different things. 61645, as it says in the actual code description itself, includes the mechanical thrombectomy, going in and removing a thrombus, okay? Also putting in a drug to help break it up, or using very specific drugs such as the 2B and 3A inhibitors, which again will help break up any type of thrombus that's in there. Now, it goes on to tell us that 61650 and 61651 describe the cerebral endovascular continuous or intermittent therapeutic prolonged administration of a non-thrombolytic agent, like a spasmolytic or chemotherapy. So again, right here, they're telling us this may match with some of our chemotherapy codes. Okay. Into an artery to treat a non-iatrogenic central nervous system disease or sequelae thereof. So again, it's telling us that we can use these for non-thrombolytic agents. Okay, so we can use these to also help with other types of disease and disorders, with different cancers and different nervous system diseases that can be improved by using these non-thrombolytic agents. Now, these codes should not be used to report the administration of agents like heparin, nitroglycerin, or saline usually administered during endovascular interventions. So again, if it's something that is typically used, so again, heparin helps thin the blood, nitroglycerin gives them a better understanding about what's going on with blood flow, and then saline again is to keep us hydrated. So just like I was talking a bit about in my medicine talk, these things normally get included, especially saline. So again, we need to know what the name of the drug is. Again, whether it's a thrombolytic therapy or a non-thrombolytic therapy. And each one of those should have a HCPCS code that goes with it. Now, this is where we get our prolonged. What does prolonged mean? Time frame. These codes are used for prolonged administration of at least 10 minutes of continuous or intermittent duration. So 10 minutes. If we hit 10 minutes, we get to use 61650. Now, It goes on to tell us the do not report 61645, 50, and 51 in conjunction with 36221, 226, 228, 37184, 37186 for a treated vascular territory, because again, those are our selective catheterizations. Okay, so those selective catheterizations are different from these. These selective catheterizations, we are doing the selective catheterization and then something else. The other catheterizations are just going in, looking around, okay? So again, we want to be as specific as possible. So we do not use any of the codes from cardiology here. We also do not report 61645 in conjunction with 61650 or 51 for the same vascular distribution. It's an either or, because 45 is talking about thrombolytic agents, 50 and 51 are talking about non-thrombolytic agents, okay? So again, what's going on with the patient's vessels? So, diagnostic angiography of a non-treated vascular territory may be reported separately. So remember, the general angiography of the vessels that we're treating is included. But if we are going to do an angiography on a slightly different area, or perhaps something comes up during the time, so what we want to make sure is that, again, is this directly related to the procedure or is this separate? If the doctor or surgeon does not describe it, then we're going to assume that it's included. So they need to be very clear on whether or not the diagnostic angiography is a separate non-treated territory. So for example, an angiography of the left carotid and or vertebral circulation may be reported if the intervention is performed in the right carotid circulation. Exactly. So in this case, angiography is on the left side of the neck, but we're doing the procedure on the right side of the neck. That is acceptable because they're different areas. They're different vessels. And again, when we get to these codes, just make sure that you go through what's included, what's not included. Now, when we get to what we call stereotactic radiosurgery, so as it tells us, cranial stereotactic radiosurgery is a distinct procedure that utilizes externally generated ionized radiation to inactivate or eradicate defined targets in the head without needing to make an incision. Okay, so what this is this is a very specific type of procedure where when we talk about imaging, one of the things that technicians and doctors learn is what we call physics of the body. Now, when we think of physics, we think about motion and how things work. It's similar to that. The physics of the body is where everything is, how large it is, and in relation to everything else. So like, for instance, when someone's learning how to become an ultrasound technician, they have to learn the physic differences between what the liver looks like, the pancreas, the spleen, the stomach, etc. Okay, so the problem is for a lot of our cranial lesions, specifically the intracranial lesions, it's not easy to get to them, and sometimes by trying to get to them, we could leave the patient with more lasting effects. So we have this stereotactic radiosurgery, and what it does, it sends a very specialized beam into that direct lesion and only into that lesion. If you want to look this up, there's some really other great YouTube videos about this where it talks about this type of physics and goes into more about how they calculate it and how they do it. It's very technical, but it's very, very interesting. And it's the major difference between what we're used to thinking of as radiation and this type of radiation is, again, the calculation and making sure that the beam exactly gets to just the lesion, not anything else. Now, they do that in regular radiation, but this is much more recent, and this is a very high mathematical calculation to get there. It's super interesting. I would highly suggest you do a little bit of research on this because this stuff is really interesting, and we're going to see stereotactic radiosurgery in a couple of places as we go forward. So we are using, again, generated ionized radiation. So the target is defined and the treatment is delivered using high resolution stereotactic imaging, uh, stereotactic radiosurgery codes, and head frame application procedures are reported by the neurosurgeon. Okay, so again, who does what? Goes on to tell us, the radiation oncologist reports the appropriate codes for the clinical treatment planning, physics, dosimetry, treatment delivery, and management from the radiation oncology section. Any necessary targeting, positioning, or blocking by the neurosurgeon is included in the stereotactic radiosurgery services. The same individual should not report stereotactic radiosurgery services with radiation treatment management. Okay, so again, if you look in radiology part 2, what you'll see is all the radiation oncology sections. We have to be careful because a lot of times the surgery portion of this is going to be done by the surgeon, and the surgeon cannot also code for the radiation oncology. Only radiation oncologists can code for the radiation oncology section and their technicians who are performing it. Okay, so these codes are for the surgeon, but they pair with the radiation oncology codes, but they cannot be billed by the same person. Okay, so keep that in mind. Although I can tell you that when it comes to stereotactic radiosurgery, the neurosurgeon and the radiation oncologist will work very closely together for this patient. So let's find out more about these lesions. So cranial stereotactic radiosurgery is typically performed in a single planning and treatment session using a rigidly attached stereotactic guiding device, other immobilization technology, and or stereotactic image guidance system, but can be performed with more than one planning session and a limited number of treatment sessions up to a maximum of 5 sessions. So again, what do they mean by mobilization? When someone gets any type of radiation in their body, we want it to go, again, directly to where it's supposed to go. On occasion, you'll see people that have like a little black dot or two on the front of their neck, just where the thyroid is. And most likely, that's a little tattoo where the radiation beam would go for things like thyroid cancer. And they do things like that. So the immobilization device holds the person in place so they can't move around that body part. So up here, when they were talking about the head frame application, it's a head frame because, again, we don't want the patient to move. If the patient moves, that radiation beam goes into a different area of the brain and can leave lasting effects. So what we want is we want the patient to be immobilized, and that's all part of it, along with the planning and the treatment session. Now, do not report stereotactic radiosurgery more than once per lesion per course of treatment when the treatment requires more than one session. So as I was saying earlier, again, specific guidelines. So they're telling us that even if we do this in more than one treatment session, which we could do in a maximum of 5, we can only code this once, and that's it, okay, because of the nature of these codes, because these codes are usually done in a one planning and treatment session, but on occasion we might have to do more, possibly up to 5, still one code per lesion, okay? Now, we have 2 main codes for simple and 2 main codes for complex. So code 61796 and 61797 involve stereotactic radiosurgery for simple cranial lesions. Simple cranial lesions are lesions less than 3.5 centimeters in maximum dimension and do not meet the definition of a complex lesion provided below. Report code 61796 when all lesions are simple. Okay, so 2 things. Number 1, size. Now, maximum dimension. Remember, let's go back to integumentary surgery for a minute. When we code the removal of lesions from the skin, we code the widest diameter. The widest diameter, not the shortest, the widest, the longest. So it's the same thing here, okay? So again, 3.5 centimeters or smaller, or anything that is not one of these down here. So Code 61798 and 61799 involve stereotactic radiosurgery for complex cranial lesions and procedures that create therapeutic lesions, like a thalamotomy or a pallidotomy. And again, sometimes the therapeutic lesions help the brain with other issues. That's up to the neurosurgeon to decide, of course. So all lesions 3.5 centimeter in maximum dimension or greater are complex. Anything 3.5 or bigger is automatically complex, okay? When performing therapeutic lesion creation procedures. So again, depending on what the specific patient's issue is, again, and there's so many different diagnoses here, I'm not going to go into all of them. It is up to the neurosurgeon to decide whether we are getting rid of a lesion or do we have to actually create a therapeutic lesion to help another issue. Okay, so again, it's up to them. So what we're looking for is how complex are these lesions? Okay, now, now goes on. When performing therapeutic lesion creation procedures, code 61798 only once, regardless of the number of lesions created. Now, so it goes on. Schwannomas, arteriovenous malformations, pituitary tumors, glomus tumors, pineal region tumors, cavernous sinus paracellular petroclivical tumors are all complex. Okay, so if they use any of those terms, they're all complex, as well as any lesion that is adjacent 5 millimeters or less to the optic nerve, optic chiasm, optic tract, or within the brainstem is complex. So again, within 5 millimeters, adjacent, next to, okay? If treating multiple lesions and any single lesion treated as complex, use 61798. And then there's a couple of do not reports. Again, 20660. Again, is in musculoskeletal. This is the removal of one of our lesions. Again, where is it? We need to be careful. And they tell us that some of these codes are going to include computer-assisted planning. So again, we're going to use imaging, you know, CAT scans, MRIs, possibly ultrasounds, nuclear medicine scans, and they're going to create basically a 3D image in the computer so they know exactly where that lesion is. Again, similar to what we do for other types of neoplasms, malignant neoplasms around the body with the treatment planning. So, I mean, when it comes to the stereotactic radiosurgery, there's not a lot of codes, but again, we have for one lesion and then each additional lesion. So be careful there, okay? Now, the next thing is the neurostimulators. Now, when we talked about medicine, we talked about the programming, reprogramming of these. These codes are for the implantation of them. We're going to see neurostimulators intracranial. We're also going to see spinal. Okay. Now, neurostimulators are used for a variety of purposes. One of the biggest ones it's being used for is for seizures. It's also used for pain. It also is being used for what we call deep brain stimulation. They've been doing a lot of testing with patients in comas that have brain activity, seeing if deep brain stimulation through a neurostimulator will help bring them out of the coma. Although, again, that's a study, so it would be catalog coded, but it wouldn't be billed to the patient's insurance because they'd be part of a study. But again, these are mainly done for different types of pain and other conditions. So the first thing is, code 61850 to 61888 apply to both simple and complex neurostimulators. For initial or subsequent electronic analysis and programming of neurostimulator pulse generators, see codes 95970 and 95975. Again, remember, the placement, the replacement, the removal, those are always from surgery. The analysis, the programming, the reprogramming, the refilling, depending, we have some drug-filled devices as well. All of that is going to come from medicine. Same thing, the pacemakers, the cochlear devices, anything that basically we implant in the body, the programming, the reprogramming, the analysis, and the filling is all going to happen in medicine. The placement, the replacement, and the removal will always happen in surgery. So, microelectrode recordings, when performed by the operating surgeon in association with the implantation of the neurostimulator electrode array is an inclusive service and should not be reported separately. Okay, because again, what we want to make sure is when we're placing this device, we are not putting it anywhere that's going to damage the function of the patient's brain. So that's what they mean by the micro electrode recording. Okay, so they're using very small electrodes to make sure that they're going in the right place and not damaging part of the brain. Now, if another individual participates in the neurophysiological mapping during deep brain stimulator implantation procedure, this service may be reported by the second individual with codes 95961 to 95962. So again, who's doing what? Always remember, whether you are coding for your class, you're coding for a test, or you're coding in the field, who are you coding for? It doesn't matter what Dr. Bob is doing if Dr. Jones is the one you're coding for. Okay, so if one doctor is doing both, it's included. If two doctors are doing two separate parts, then one can code for the implantation and the other one can code for the neurophysiological mapping. And again, like we started out talking about this in the nervous system, we have to use things like twist drill or burr holes, craniectomy or craniotomy to get it into there because we need to get this probe into the skull. And again, you can see here, this is twist drill or burr holes. And again, cortical, so where are we placing this? Okay, again, this is what it actually looks like itself. So again, this one is going into the brain. And again, we have the probe here. This is then going to be pulled down through the connective tissue in the neck and implanted in the upper chest. And again, this is the pulse generator. The pulse generator is what we need to analyze, program, and reprogram. Okay, and again, those codes are all in medicine. Now, as we continue going through, again, we're going to see repairs, we're going to see neuroendoscopy, we're going to see some things about the cerebrospinal fluid shunt as well, but none of those have guidelines, so it's all about the exact procedure. So when it comes to the rest of the codes that are in the brain themselves, what specifically are we doing? And remember, you can look up the name of the procedure like craniectomy, craniotomy. You can always look up the main term of brain. You can always also look up things like stereotactic. So, you know, when it comes to the codes that deal with the brain themselves, what are we doing? And to what part of the brain are we doing it to? Because again, there's so many different parts of the brain. The other thing that you have to keep in mind for a lot of these codes is approach. Just like when we were talking about the skull-based surgery earlier, what is the approach they're using to get to that part of the brain? Okay, so now we're going to start talking about the spine and spinal cord. And there are quite a few guidelines that we're going to get. And we're going to see some definitions happen over and over and over again because in the last few years, we have revised and updated a lot of these codes. So the first thing it tells us is injection of contrast during fluoroscopic guidance and localization is an inclusive component of all of these codes. I'm not going to read them, but there they are. Okay. So again, the injection of contrast is inclusive. Fluoroscopic guidance and localization is reported with 77003 unless a formal contrast study like a myelography, epiderography, or arthrography is performed, in which case the use of fluoroscopy is included in the supervision and interpretation code or the myelography via lumbar injection code. So again, if we're doing a formal study, then the contrast is going to be included in the code descriptor. If we're not, then we have to code separately. And it goes on to tell us, image guidance and the injection of contrast are inclusive components and are required for the performance of myelography as described by codes 62302, 303, 304, and 305. Okay, so again, it's giving us an indication this is what's coming next. Okay. Now, again, remember, some radiological supervision interpretation will be included. Other times it will be separate. So always look out for those notes underneath the codes. So for radiological supervision interpretation of an epiderography, use 72275. Code 72275 is only to be used when an epidurogram is performed, image is documented, and a formal radiographic report is issued. So basically, they're giving us an indication right now that this needs to, again, be a formal written report. And that is one of the things we have to keep in mind. When it comes to imaging, it needs to be saved in a formal way, whether it's virtual or if they're still using film, depending. And then there has to be a written report that goes with it. If that doesn't happen, and then it's usually just part of a surgery and we can't code it separately. So if they're just using imaging to make sure they're in the right place and they don't do a formal written report, that could be problematic. All right. So it goes on. Code 62263 describes a catheter-based treatment involving targeted injections of various substances like hypertonic saline, steroid, or anesthetic via an indwelling epidural catheter. So again, for instance, this is kind of like what I call the button, right? This is a way of being able to use a variety of different drugs to help get rid of lesions. And in this case, it says percutaneous lysis of epidural adhesions using solution injections or mechanical means, including radiologic localization. Includes contrast when administered. We have 62263 specifically is multiple adhedolysis sessions, 2 or more days, and its indented code 62264 is for 1 day. So again, this is when we are specifically going in to get rid of lesions. So again, it includes the percutaneous insertion or removal of an epidural catheter remaining in place over a several-day period for the administration of multiple injections of a neurolytic agent performed during serial treatment sessions, again, spanning 2 or more treatment days. If required, adhesions or scarring may also be lysed by mechanical means. So again, as I was reading in the code, we can use drugs or we can use a mechanism. Code 62263 is not reported for each adhedolysis treatment, but should be reported once to describe the entire series of injections and infusions in spanning 2 or more treatment days. So again, this is what I was talking a little bit about earlier. Some of our codes are, doesn't matter how many times we do it, it's one code. So whether we do this for 2 days, 3 days, 5 days, 7 days, 14 days, 62263 is the only code we can use to describe that procedure, okay? However, if it's relatively simple, code 62264 describes multiple adhedolysis treatment sessions performed on the same day. Adhesion or scarring may be lysed by injections or neurolytic agents. If required, adhesions of scarring may also be lysed mechanically using a percutaneous deployed catheter. So again, 62263, as it tells us, is 2 or more days. 62264 is 1 day only. Now again, these codes include the procedure injections of contrast for the epidural and fluoroscopic guidance and localization during initial or subsequent sessions. So again, it includes the imaging. Now, fluoroscopy or CT and any injection of contrast are also inclusive components of code 62321. 323, 325, 327, okay? But if we're doing an epidural for those codes, we have to use 72275. So again, what are we doing? So as we go to this next series of codes, the 623s, these are injection of diagnostic or therapeutic substances, such as an anesthetic, antispasmodic, opioid, steroid, or other solution, not including neurologic substances, including neither needle or catheter placement, interlaminar, epidural, or subarachnoid, cervical, or thoracic, without imaging guidance. And then we have an indented code with imaging guidance. So these are injections of other therapeutic substances. Okay, so let's keep that in mind as we go through the guidelines. The placement and use of catheters to administer 1 or more epidural or subarachnoid injections on a single calendar day should be reported in the same manner as if a needle has been used, i.e. as a single injection using either 62320, 21, 22, or 23. Such injections should not be reported with 62324, 5, 6, or 7. So again, Be careful what is and is not reportable with these codes. It goes on, threading a catheter into the epidural space, injecting substances at one or more levels, and then removing the catheter should be treated as a single injection. Again, now, as we go through, what we need to know is, again, what are we doing? Where are we doing it? So, it tells us, if the catheter is left in place to deliver substances over a prolonged period of time, more than one calendar day, either continuously or via an intermittent bolus, we use 62324, 25, 26, and 27 as appropriate. So again, we have to be careful because it's going to tell us one day, multiple days. So keep in mind. Now, when reporting these codes, 62320, 21, 22, 23, 24, 25, 26, and 27, code choice is based on the region at which the needle or catheter entered the body, like the lumbar region, the cervical region, the sacral region. Where are they putting in that original needle or catheter? So code 62320, 21, 22, 23, 24, 25, 26, and 27 should be reported only once when the substance injected spreads or catheter tip insertion moves into another spinal region. So for instance, 62322 is reported only once for an injection or catheter insertion at L3 to L4 with spread of substance or placement of the catheter tip to the thoracic region. Again, one code. It goes on to remind us percutaneous spinal procedures are done with indirect visualization. Again, we're using imaging guidance. Okay, again, we're using fluoroscopy, we're using that x-ray equipment. Endoscopic assistance during an open procedure with continuous and direct visualization, which is usually light-based, is reported using the excision codes 63020 to 63035. Why? Because these are percutaneous procedures. Again, we're going in through a puncture versus slice and dice, which starts at the 63020. Now, as we continue to look at all of these, the biggest thing that we're going to see is this series of definitions over and over and over again. And they're placed in, I want to say, 3 to 4 different parts of the nervous system surgery. So we're only going to go through these once, but note that there are other, basically copy-paste versions of this directly in other sections to remind you about these. Again, the biggest thing that we're seeing now is we're trying to do different types of procedures. We're trying to get them smaller, but it depends on the patient, it depends on the surgeon, it depends on the condition. So, for the purposes of CPT coding, the following definitions of approach and visualization apply. The primary approach and visualization define the service, whether another method is incidentally applied. So again, primary approach. Surgical services are presumed open unless otherwise specified. And that's really something that goes for the whole surgery section. Again, if it does not say that we're doing it percutaneously, we're doing it through a catheter, we're doing it this way, we're doing it that way, it's assumed to be an open procedure. So percutaneous means image-guided procedure like computed tomography or fluoroscopy, performed with indirect visualization of the spine without the use of any device that allows visualization through a surgical incision. So again, percutaneous, we're going through the skin to get there. Percutaneous, through the skin, usually into a vessel. Endoscopic are spinal procedures performed with continuous direct visualization of the spine through an endoscope. Open are spinal procedures performed with continuous direct visualization of the spine through a surgical opening. Indirect visualization is considered image-guided, like C2 or fluoroscopy, not light-based visualization. And then we have direct visualization, which is light-based visualization that can be performed with the eye, surgical loops, microscope, or endoscope. So again, what type of procedure are we doing for the patient? We need to be careful. Now, Just to give you a heads up, on page 404, you are literally going to see those same definitions of percutaneous, endoscopic, open, indirect, and direct visualization, as well as on page 405. You're going to see the same thing. So just keep in mind, again, they're just doing reminders. So I didn't highlight each and every one of them because they are the same word for word. But again, you'll notice that as the years go by, especially those of you who might have started coding in 2017 or before, this is the first year the CPT book has been in full color. And you'll have noticed that in the last couple of years, they've added in a lot more notes that are very helpful. And so again, if it's helpful for you to re-highlight these definitions, then do it. It's your book, whatever makes you happy. All right, so as we've been talking about all of these different types of procedures, the one thing that we have to keep in mind is exactly what we're seeing here, the decompression. So what happens a lot of the time is we need to fix a problem with an intervertebral disc. Okay, it can bulge in towards the body, it can bulge out from the body, it can bulge to the left, to the right, etc. So when we're doing most of these surgeries, a lot of times there's going to be two surgeons that work together. So always keep that in mind, okay? For the following codes, when two surgeons work together as primary surgeons, performing distinct parts of spinal cord exploration and decompression operation, each surgeon should report his or her distinct operative work by appending modifier 62 to the procedure code and any associated add-on for the procedure code as long as both surgeons continue to work together as primary surgeons. Again, in this situation, modifier 62 may be appended to the definitive procedure codes 63075, 77, 81, 85, 87, and 90 as appropriate, and to the additional interspace add-on codes 63076, 63078. And for additional segment add-on codes 63082, 86, 88, and 91, as long as both surgeons continue to work together as primary surgeons. So again, remember, modifier 62 is co-surgeons. So that means they're working at the same level throughout the procedure or procedures. So again, we have to be careful. As soon as one starts talking about how the other started assisting in a surgery versus being a co-surgeon, that's when we have to worry about whether or not we can append the modifier 62. Now, again, some revised wording here that helps us. So again, for the vertebral corpectomy, so again, the removal of part of the vertebrae, what we're using is we have the term partial is used to describe the removal of a substantive portion of the body of the vertebrae. In the cervical spine, the amount of bone removed is defined as at least 1/2 of the vertebral body. In the thoracic and lumbar spine, the amount of bone removed is defined by at least 1/3 of the vertebral body. And just as a reminder to you guys, at the beginning of the nervous system, this is on page, oops, sorry, not the nervous system, I apologize, the musculoskeletal system. So for musculoskeletal, the pictures of the vertebrae are on page 104. Shows you a picture of the lumbar and the thoracic vertebrae. And it gives you the definitions of the body versus the processes versus the lamina versus the facets. And so again, don't forget, page 104 is always here to help you. Also, depending on which ICD-10 book you have, you might have even better pictures of the spine itself. So we're going to see this piece again a couple of times as we continue to go through. And again, you can highlight it or not highlight it more than once. It's really up to you and what you feel comfortable with. And again, these are the discectomies. So again, we're removing the discs and then doing decompressions. So again, the biggest thing is what's the approach? How are we getting there? Okay, we have transpedicular, costovertebral, posterolateral, anterior, anterior lateral, extradural, lateral. So we have a lot of different choices. What is the approach? Okay, so remember, approach is not always important in every section of the book. It is very much so when it comes to nervous system surgery. So again, for the anterior or anterolateral approach for an intraspinal lesion, again, it still talks about two surgeons and modifier 62, and it lets us know in this situation, modifier 62 may be appended to the definitive procedure code 63300 to 63307, and as appropriate to the associated additional segment add-on codes 63308, as long as both surgeons continue to work together as primary surgeons. So again, it's giving us the indication, and then again, the same exact definition for what partial means as well. So again, if you want to re-highlight that, go ahead. If you don't want to, you don't have to. Again, your books or yours and anything written in your book is fair game for certification or credentialing exam. Okay. All right, so now we're looking at our spinal neurostimulators. And again, these are going to be similar to the cranial neurostimulators. So codes 63650 to 63688 apply to both simple and complex neurostimulators. For initial or subsequent electronic analysis and programming of neurostimulator pulse generators, see codes 95970 excuse me, to 95975. Code 63650, 63655, and 63661 to 63664 describe the operative placement, revision, replacement, or removal of the spinal neurostimulator system components to provide spinal electrostimulation. A neurostimulator system includes an implanted neurostimulator, external controller, extension, and collection of contacts. Multiple contacts or electrodes, 4 or more, provide the actual electrical stimulation to the epidural space. So again, we're going to have a battery pack, and we're going to have a probe, and sometimes we also are going to have a separate external device that connects to the internal device. Now, for percutaneously placed neurostimulators, 63650, 61, and 63, the contacts are on the catheter-like lead. An array defines the collection of contacts that are on one catheter. For systems placed via an open surgical exposure, 63655, 63662, and 664, the contacts are on a plate or paddle-shaped surface. So again, how they're implanting these are going to be some of the differences between the codes. Do not report 63661 or 63663 when removing or replacing a temporary percutaneous placed array for an external generator. So again, these are for permanent. So again, how are we getting there? We have percutaneous and we have open, and then where on the spine are we doing this? So again, this has the electrode plates that they put on the spine. And then the picture underneath this, the picture above this has the percutaneous as well. And so again, you can see here, we have the external transmitter, and then we have the internal receiver that can go up to this area. So again, where's the neurostimulator going? Is it going into the brain? Is it going to the spine? Or in this case, is it going into the peripheral nervous system? So code 64555 to 64595 apply to both simple and complex neurostimulators. For initial or subsequent electronic analysis and programming of neurostimulator pulse generators, see 95970 to 95975. Again, it reminds us that an electrode array is a catheter or other device with more than one contact. The function of each contact may be capable of adjusted during programming services. Again, insertion, replacement, revision, removal, surgery, programming, analysis, medicine. So codes 64553, 555, and 561 may be used to report both temporary and permanent placement of percutaneous electrode arrays. Code 64550 describes applications of a surface transcutaneous neurostimulator. So that's the TENS unit at any anatomical site. Okay, so again, what we need to know is where are we placing this? So we could be doing it at any anatomical site. We have the cranial nerve, peripheral nerves, tibial nerves, sacral nerves. So again, where are we placing these electrodes? Now, when we get to the next page, this is page 415. Now we're looking at destruction by neurolytic agents, okay, and chemodenervation. So sometimes when a nerve is overacting and doing something it's not supposed to be doing, we can destroy that nerve impulse. And so we can do it by an injection, or we can do chemodenervation, which will also destroy the signal as well. So codes 64600 to 64681 include the injection of other therapeutic agents like corticosteroids. Do not report diagnostic and therapeutic injections separately. So they're telling us that this includes the injection itself. Do not report a code labeled as destruction when using therapies that are not destructive of the nerve target, like pulsed radiofrequency. Use 64999. So again, they're telling us these are destructive procedures. If we're not doing a destruction procedure, we're going to go to the unlisted service. For codes labeled chemodenervation, the supply of chemodenervation agent is reported separately. So again, we're going to go into our HCPCS for this. So the biggest thing here is, again, where are we going? We have our somatic nerves. Again, what are we doing? We have the chemodenervation, and we also have the destruction by neurolytic agents. We go to page 416. Before we get to the paravertebral facet joint nerves, there are these guidelines. Report 646, 33, 34, 35, and 36 per joint, not per nerve. Okay, important. Remember, guidelines tell us what is included in these codes. So it's telling us these codes are per joint, not per nerve. Although two nerves innervate each facet joint, only one code may be reported for each joint denervated, regardless of the number of nerves treated. Use 64634 or 64636 to report each additional facet joint at a different vertebral level in the same spinal region. And then also reminds us, for neurolytic destruction of the nerves innervating the T12 to L1 paravertebral facet joints, use 64633. So they're giving us an indication right there that that is a very common place. However, do not report 64633, 34, 35, or 36 for a non-thermal facet joint denervation, including chemical, low-grade thermal energy, or any form of pulse radiofrequency. Okay, so again, this is specifically for the destruction by the neurolytic agent. So again, how we're performing the surgery is how we separate them out. So we can see here, destruction by neurolytic agent, paravertebral facet joint with imaging guidance, cervical or thoracic single facet joint, each additional facet joint. So again, we need to be careful. We also have lumbar or sacral as well. It goes on in the next page as we are going towards the extremities now. Report 64642 and 64643, 44, and 45 once per extremity. These codes can be reported together up to a combined total of 4 units of service per patient when all 4 extremities are injected. Report only one base code, 64642 or 64644 per session. 64622 is chemodenervation of one extremity, 1 to 4 muscles. 64644 is chemodenervation of one extremity, 5 or more muscles. So again, how many injections are we making? We start with one standalone code. Then report one unit additional extremity codes, 64643 or 45 for each additional extremity injected. So again, we need to know how many extremities and how many injections in the muscles in those extremities. Okay, and it tells us to go to 64646 and 47 for muscles of the trunk. It goes on to tell us trunk muscles include the erector spinae, paraspinal muscles, rectal abdominis and obliques, all other somatic muscles and extremity muscles, head muscles, or neck muscles. So again, what part of the body are we going into? That's how they separate up this code. So again, anatomic site. And again, 1 to 4, each additional. We can only use one standalone with its paired add-on code. Now, as you go to page 418, this is where we get to the neuroplasties, which include exploration, neurolysis, and nerve decompression. And so they tell us neuroplasty is the surgical decompression or freeing of an intact nerve from scar tissue, including external neurolysis and or transposition to repair or restore the nerve. So again, different ways that we can do this. What we really need to be careful is, where are we doing the neuroplasty? We can do fingers, hand, foot, peripheral nerves, cranial nerves, so again, where specifically are we doing these? So as we go down again, this is digital, okay? So again, fingers and toes, hand and foot, arm or leg, sciatic nerve. So again, if we're doing a neuroplasty, where are we doing the neuroplasty? Now, we also have a couple other sets of codes that don't have any guidelines that finish off this section. We're also going to see excision of some nerves. Again, sometimes we have to remove a nerve from the body for a specific reason. We're also going to see the neurorapies. So remember, way back in the tegumentary surgery, for wound repairs, it tells us that if there are any major nerve damage or blood vessel damage, we have to go to the specific section to use an additional code. Well, starting at code 64831 is a different neurorapies. So again, if we need to suture a nerve because of an accident or injury, it's there as well. And then the last section is neurorapy with nerve graft, vein graft, or conduit, starting at 64885. So this is suturing a nerve and using a graft at the same time. So again, when it comes to reconstructive procedures, we may see these codes as well. Keep in mind, the majority of people who are going to be using nervous system surgery are going to be our neurosurgeons, but we may also see some of these in wound repairs, reconstructive surgery, plastic surgery. So keep that in mind. All right, guys, good luck with the endocrine and nervous system coding for CPT.